Hello, everybody. Thank you for tuning in. My name is Madeline. I go by Maddie. Today, we're going to be talking about coronary heart disease. I'm going to cover the pathophysiology, risk factors, manifestations, and the treatments that we see for this very prominent disease in the United States. So, without further ado, let's get started. All right, so what is coronary heart disease? I am sure we all know this from nursing school, just kind of a review, but the coronary heart disease is a disease that affects the coronary arteries, which branch off the aorta that is supplying blood from the left ventricle to the rest of the cardiac muscle. You can see here on the right-hand side a little diagram. You have like your left coronary artery, circumflex, right coronary artery, and anterior descending artery. These all supply that freshly oxygenated blood so the cardiac muscles can keep um, presuming their functions. Any clots or atherosclerosis, plaque buildup in there can cause problems that lead to insufficient oxygenation of these cardiac muscles. And you can see over here the left anterior descending artery, that when that becomes occluded, it is actually called the widowmaker because it is very hard to come back from a lack of oxygenation to your left ventricle, which supplies blood to your entire body, as well as your coronary arteries, so the heart cannot function beyond past that. It generally leads to a severe heart attack and most likely cardiac arrest. Also, you can experience dysrhythmias and even heart failure. And coronary heart disease is responsible for 1 in 6 deaths in America. So, this is the coronary heart disease umbrella. This is how I like to differentiate it in my mind with all these various conditions that are included in coronary heart disease. So, you have angina pectoris, and then you have myocardial infarction side. Angina is a temporary inhibition of blood flow, normally caused by vasospasm or, a slight narrowing that causes the inhibition of blood flow. It is then further differentiated in between stable and unstable angina. Stable angina is reproducible, reproducible. I like to think of this as somebody walking down the stairs, they get really bad chest pain, they sit down on the couch, and it goes away. However, unstable angina would be if they're sitting on the couch watching TV, out of nowhere, they just get really bad chest pain, and it is not relieved with rest. A lot of the times they'll have to use nitroglycerin or end up taking themselves to the ER. Now, it is very hard in modern day medicine to distinguish between unstable and an NSTEMI because we often get treatment sooner. However, the biggest differentiator is that unstable angina will present with no elevated serum biomarkers such as troponin and CKMB, but an NSTEMI will have these elevated troponin and CKMB. Now, NSTEMI is when there's no ST segment elevation and you can take a little bit more time. It's not as life-threatening. However, a STEMI is what we typically think of as a heart attack, where you have that ST segment elevation, those tombstones, and they will have significantly elevated troponins, and they most likely need cath lab immediately or intervention so that it does not lead to cardiac arrest or other severe dysrhythmias that lead into that cardiac death. So, atherosclerosis, I have termed this the CAD culprit that we all know and love, not really love, but it is the accumulation of lipids and fibrous elements and the calcification of the arteries that leads to all these symptoms we are going to talk about. The vessels narrow and inflammatory pathways become activated to cause thrombus formation. You can see up at the top, I've shown an artery that is normal without atherosclerosis, and then below it is a artery with atherosclerosis, that narrowing of that vessel. All right, so the pathogenesis of atherosclerosis. This is a complex process that occurs over time, and symptoms may not be seen for months to years. So it begins with any damage to the endothelium, the arterial endothelium. Most commonly, occurs from turbulent blood flow that we see in hypertension. So the endothelium becomes damaged and then it becomes permeable. So this LDL that's circulating in the blood can then go underneath and start forming that fatty layer. And patients with higher LDL, they will be more susceptible to have that increased concentration of LDL forming the fatty streak. Once this occurs, it triggers an inflammatory process. So it recruits monocytes, which turn into macrophages, which eat that LDL and they form foam cells. Now, with these foam cells, it then forms this unstable fatty lipid core and it becomes calcified over. And any damage to the calcified plaque it puts them at risk for plaque rupture. When the plaque ruptures, it causes the trigger of coagulation cascade, and it forms a thrombus that is responsible for the symptoms of a heart attack and essentially blocking the blood flow to the cardiac muscle. Now we'll go over the risk factors for developing coronary artery disease. These can be divided into those non-modifiable risk factors, such as gender, the ones that you really are born with and can't change, and modifiable risk factors, those lifestyle choices that can be altered to prevent the coronary artery disease from occurring. All right, so non modifiable risk factors, age is one of them. Men older than 45 are at higher risk for developing coronary artery disease, and women over the age of 55. So, simple biological clock puts you at greater risk. Also, males are at higher risk for developing this, and family history. Any patient who presents with a first degree relative that has had an MI or sudden cardiac death is also at greater risk for having a heart attack themselves and developing this heart disease. So, one of the biggest modifiable risk factors that we can impact as nurse practitioners is controlling a patient's dyslipidemia. When patients have a total cholesterol greater than 200 milligrams per deciliter and an LDL greater than 130 milligrams per deciliter, it puts them at higher risk. This LDL is said to have a very high concentration of cholesterol, and it's been linked to the highest risk of developing plaque. So, this is something we really want to hone in on, is getting the LDL below 130 to reduce their risk. Also, triglycerides being over 150 milligrams a deciliter and HDL being less than 40 milligrams a deciliter. Now, HDL is often termed the good cholesterol, and it is responsible for transporting cholesterol from the peripheral tissues back to the liver, thus removing the ability to form those plaques and develop the ischemia symptoms. So, other lifestyle risk factors, hypertension, which we talked about earlier, causes that turbulent blood flow, leading to the damage of that endothelium. So, we really ideally want patients' blood pressure to be under 140 systolic, and this can be controlled through medications. Other lifestyle modifications, cigarette smoking also is a big one. Cigarette smoking, it inhibits the vasodilation ability and increases inflammatory markers, and it also places patients at risk for increasing platelet adhesion, which leads to those thrombus formation. Diabetes, it also leads to increased dyslipidemia and inflammation levels, and obesity also contributes to dyslipidemia with the excess fatty tissue, as well as high blood pressure and just overall inflammation. And so, some piggybacking off of obesity, physical inactivity and poor diet tend to lead to obesity, and it's kind of a trickle down effect for all of these. So, what happens when you do experience ischemia? So, your myocardial cells have no ATP reserves, which makes them very sensitive to any disruption in the oxygenated blood flow. They cannot function without that constant supply. So, this is why coronary heart disease causes so many problems. There is two ways ischemia can occur. It's either when the coronary perfusion is impaired, so the supply, or the workload increases, so the demand. So perfusion can be impaired when a large stable plaque narrows the lumen, or acute platelet aggregation or thrombus, vasospasm, or just an overall low blood pressure leading to poor perfusion. And the myocardial workload, it depends on heart rate, preload, afterload, contractility. So there has to be this delicate balance of supply and demand in the heart. Now, symptoms do not typically present until you have a 65 to 75% of the lumen being occluded. And so because this happens significantly over time, you'll often see collateral blood flow or alternative circulatory pathways develop to avoid this. Clinical presentation. How are these patients presenting to our offices, to the emergency department, in their homes with EMS? So, typical ischemia symptoms are that chest pain that we think of, that crushing, it radiates into the arm, the jaw, the back. Patients will be diaphoretic. They'll have arrhythmias. They'll feel dizzy, want to vomit, nauseous, and almost feel like they're going to be passing out. This is simply because we are not getting enough oxygen to our heart and our tissues and our brain. Now, once we head into severe ischemia, that is more the realm of the NSTEMI, STEMI. So tachycardia is a compensatory mechanism due to the heart not meeting the cardiac output, And so it tries to increase the rate to make up for it. And hypotension occurs due to the cardiogenic shock. So heart's not functioning as it should. And so you begin to see this lack of blood flow and the low blood pressure. Lethal rhythms, most commonly seen in a STEMI, VFib, VTAC, very life-threatening cardiac arrest is imminent. Pulmonary edema, now when the left ventricle is not functioning appropriately, you will see the blood flow back up into this pulmonary system, causing excess fluid on the lungs, and they can present extremely short of breath. Cool extremities, very, very late sign. Once again, due to the left ventricle not functioning, you're not getting enough blood flow to your extremities. And something to keep in mind is that women tend to present atypically, and anybody over the age of 55, you really need to make sure you ask them a bunch of questions and figure out, that they'll present with just general fatigue and some slight nausea. So making sure that you're performing an EKG on these women who present with kind of these non-specific symptoms. Differential diagnosis. So when patients present with chest pain, there's a world of things that it can be. And we'll need to rule out some very severe conditions and then consider others and perform tests to ultimately figure out what's going on. So the severe conditions we need to rule out is the aortic dissection, a pulmonary embolism, tension pneumothorax, cardiac tamponade, cardiac arrhythmias, and then one of these is also the STEMI and NSTEMI, which we refer to as acute coronary syndrome. So to do this, we'll need to do EKG, chest x-ray, and test their blood for the troponin, the serum biomarkers. Now, I've seen it in the emergency department. Patients come in with chest pain, and it can be more simple causes. So some other ones to consider, they could have a heart failure exacerbation, myocarditis, aortic valve disease, cardiomyopathy. Now, pneumonia can cause chest pain, a COPD flare-up, pleuritis. Now, one we really see in the emergency department is GERD, and patients present with this crushing chest pain, and it's actually acid reflux, which if patients haven't experienced before, that can feel pretty similar. Esophagitis, they'll have rib pain, or they could have trauma. Now, anxiety or panic attacks can cause that chest pain feeling. And then also methamphetamine and cocaine. Now, a lot of times cocaine causes that vasospasm of the heart. And so patients that have used cocaine for the first time can actually have a heart attack. And that would be the most common reasons a younger patient would present with a heart attack. So how do we diagnose acute coronary syndrome? Anytime a patient presents with chest pain, first thing we do, we get an EKG. We rule out that STEMI, the ST elevation. No ST elevation, we must do a further workup. Now, the EKG may show a flutter, sinus tach, sinus Brady, and then we need to treat accordingly. However, we may need to enter into doing a chest x-ray, testing their blood. And with troponin, now there's many different types of troponin that we can test for. There's troponin 1, troponin 2, you can see in this chart over here. The one that I am most familiar with is the high sensitivity troponin. Normal range, anything between that 0 and 20. Now, anything greater than that, greater than 20, we're moving into the ischemia territory. And obviously, the higher the number, the more likely the patient is to be having severe, even necrosis of the tissue. I've seen patients present with troponins of 700, even 1200, and they are severely ischemic in their heart. We're going to talk about EKG interpretation now. So, from nursing school, you guys, I'm sure you all remember the ST elevation, the tombstones, what that looks like, the P, QRS, all that stuff. I'm not going to review that, but specifically, I feel like we did not get enough coverage on a 12 lead interpretation. So, here I have a kind of spread out of a 12 lead and then where that correlates to on the heart. So there's within certain leads, it shows us a certain view of the heart. So if we see an elevation in that certain segment, it's signifying that the occlusion is going to be in that specific area of the heart. So over here you see in leads 2 and 3 in AVF, that's inferior, and in 2, 3, V2, V3, and V4 is anterior. And then at septal is going to be V1, V2, and then lateral is going to be V5 and V6. So that just kind of helped me wrap my head around it. A better photo, if you look over to the right, it shows you the actual anatomical heart, and then it shows you which area would be correlated to which lead. So once again, lateral, you see here in that blue is the lead 1 AVL. And then another lateral is V5, V6, anterior is V3, V4, and then septal is V1, V2. It just helps to visualize as a nurse practitioner what you're looking at when you look at the EKG. Now, down below, I have a sample of an EKG where they're having an acute MI, and it is an inferior MI. So if you look down there, you can see that ST significant elevation in leads 2 and 3. And if you look up at the photo above that, inferior 2, 3, and AVF. And so that is significant that the patient is having a inferior MI. So I hope that kind of helps a little bit to kind of break up the 12 lead interpretation, because I know it can be a little bit intimidating. All right, so going away from content for a minute, let's go for a case study. So, based on the symptoms Ms. Johnson presents with, what is our differential diagnosis and what testing should we be running? So, Ms. Johnson is a 67-year-old female. She is a retired nurse. She does have a history of hypertension, hyperlipidemia, and type 2 diabetes. She takes 10 milligrams of lisinopril daily, 20 milligrams of atorvastatin, and 81 milligrams of aspirin. She presents to the emergency department complaining of fatigue, shortness of breath, with simple exertion for the last 3 hours. She endorses some upper back pain and shoulder soreness with some intermittent indigestion. She states that her back pain intermittently radiates into her abdomen and her neck, and she also appears visibly anxious to the triage nurse. Her vital signs: her blood pressure is 165/90, heart rate is 108, and respiratory rate is 22. Her oxygen is 97% on room air, and her temperature is 97.9. So I'll pause and give you guys a minute to think about what we would be our differential diagnosis and what we think we should run as far as testing. So, based on these symptoms, we can make a differential diagnosis of STEMI, GERD, anxiety versus pulmonary embolism versus flu symptoms. She's presenting very with just fatigue, not feeling well, that upper back pain, the soreness, and she's just kind of not, presenting with anxiety. So our first step is to obtain an EKG. We need to start an IV, draw basic lab panels and a troponin, get a chest x-ray, and perform a full head-to-toe assessment. So, upon our head-to-toe assessment, she's neurologically intact. She has normal lung sounds. She's breathing slightly fast. Her heart rate, you can see, was 108, slightly tachycardic, and also her blood pressure was 165, so slightly hypertensive. Her EKG, there's no ST elevation, so we can rule out that acute heart attack. And gastrointestinal, she is having that epigastric pain, the kind of burning sensation, and she's urinary wise completely normal. And musculoskeletal, she does have that pain in her upper back, shoulders, just kind of generalized, just aching in her upper body. And your troponin test comes back and it is 245 nanograms per liter. So, what is our diagnosis for Miss Johnson? I'll give you a minute to think about it. So, if you guessed NSTEMI, you are correct. Now, she presented with the extremely elevated troponin, but her ST segment was not elevated on her EKG. So we ruled out that life-threatening heart attack. However, with that troponin, we can now pinpoint that it is an NSTEMI and not unstable angina, because remember that the differentiating factor between those two is the elevated troponin. Now, what in her history contributed to this development? Well, we can go back to the risk factors. Her having the high blood pressure, that turbulent blood flow damaging the endothelium, her having hyperlipidemia. So when the endothelium is damaged, she has that excess LDL in her bloodstream that enters into forming that fatty streak. And then also her having diabetes can further increase the inflammatory levels. And so what are we going to do for Miss Johnson? What do we do in general for these patients? We will now move into the treatments. So the best way to treat ACS is to prevent atherosclerosis from occurring in the first place. Now, these can be just simply by targeting these risk factors. So controlling the modifiable ones, eating a healthy diet, exercise, stopping smoking, and managing stress levels. Also managing comorbidities. So patients with hypertension, ensuring they are taking their blood pressure often, taking their hypertension medications, and diabetes as well, making sure their sugars are well controlled. We're not further damaging these vessels. So it is really important to check their hemoglobin A1C and ensure maybe they're keeping a blood pressure log. Also, pharmacological intervention. They need to be taking their statins, and they need to also PCSK9 inhibitors. So there is genetic familial hyperlipidemia, where patients, no matter what they eat, no matter what they do, they have a genetic cause that makes them susceptible to having this high cholesterol. So PCSK9 inhibitors go in, and they're actually a drug that target the genetic cause of hyperlipidemia. So considering this for patients and testing them for the genetic cause behind it. And also antiplatelets. The 81 milligrams of aspirin per day is preventatory for in case there is a plaque rupture. And we have this, in the inflammatory coagulation cascade is being triggered. It prevents that platelet from forming in the first place. Treatment of NSTEMI and unstable angina. I group these together because there is a common ischemia treatment that we follow for all these, but there is some differentiating factors because NSTEMI is more severe than unstable angina. Once again, differentiating between these is simply through a troponin level. So general ischemia treatment, we always want to administer oxygen to keep their stats above 94%. If they are experiencing ischemia to the heart, they're not getting enough oxygen, we're just upping their oxygen concentration in their blood. Nitroglycerin is a great medication that is a vasodilator. It opens up the coronary arteries to allow for blood flow if there is that narrowing. However, we need to be careful with this medication as it can cause hypotension. So taking a blood pressure before we give this, as a patient's hypotensive, it is contraindicated. Now, also something to consider with nitroglycerin is Viagra is a vasodilator, so we need to ask them, men and women, if they have taken Viagra before we prescribe this nitroglycerin. Morphine, this is another medication we need to be cognizant about blood pressure with. This can be given as treatment. Sometimes nitroglycerin develops a severe headache, and so morphine can help with that as well as the chest pain. But the headache can also be treated with Tylenol for these patients. Antiplatelet therapy. Our patients who are at risk for developing heart disease, we should have them on 81 milligrams of aspirin daily as an antiplatelet in case that platelet aggregation does occur. But we need to make sure that if they're having an acute episode, we need to give them 324 milligrams of aspirin. Unstable angina, this one it does not often require hospital admission unless it's their first time or we're very concerned about them. We can refer them out to a cardiologist, and they can get a stress test, identify what risk factors they have, and what stage they're in for this. Nitroglycerin, we can also give them the prescription, but we need to ensure we are educating them on when they can take it. Every 5 minutes for 3 doses. If it doesn't work, you need to call 911. And if you start to feel dizzy, give them those parameters so that they can safely give that to themselves. And NSTEMI, we will need to admit these patients for observation. We'll need to trend their troponin to see if it's getting better or if it's getting worse. Typically every 6 hours is what we see. And they also potentially may need to be taken to the cath lab for stenting, for the percutaneous coronary intervention. So they'll go through the artery of the wrist or the femoral, and they'll be able to access the heart so that they can put in a prophylactic stent, because an NSTEMI is a warning sign that a STEMI is brewing in their near future. STEMI, how are we treating these acute heart attacks? Now, something to consider: if we are in a doctor's office and we do an EKG and the patient presents with the tombstones, we need to immediately call 911, and they need to be transported to a cardiac receiving center. Now, once they're at that cardiac receiving center, this is the typical treatment that will occur. So drugs similar to the NSTEMI, nitroglycerin, morphine, oxygen, aspirin, the 324 milligrams of aspirin. Now at a doctor's office, we might be able to actually give them the 324 of aspirin before EMS arrives. If not, EMS tends to give that 324 milligrams of the antiplatelet therapy. Heparin is one that we will give for STEMIs, which is another anticoagulant. It doesn't prevent the clot. It doesn't eat the clot, but it does prevent the clot, any additional clots from forming, making sure that the heart attack doesn't get worse. Now, managing arrhythmias. these patients that are experiencing severe heart attacks tend to flip into VFib, VTAC, asystole. So we need to follow our ACS protocol and administer any antiarrhythmics such as amiodarone, epinephrine. These are life-threatening, and they unfortunately will not stop until we get to the cath lab. Now, cath lab is where a cardiologist will perform a percutaneous coronary intervention, or PCI. So they go through the arteries either in the wrist or the groin, and they'll go up into the heart to see what's going on and see which occlusion is happening. So our goal is 90-minute door to balloon time. So the moment they enter into the emergency department, we want them to be on a cath lab table under the needle or with the balloon inflated in the area within 90 minutes. Now, in some rural areas, PCI is not available, and so we need to consider thrombolytics. So this would be tenecteplase. It is a clot-eating medication. So unlike heparin, which just prevents clots, this actually goes in and eats any active clots that are in there. So this treatment is necessary, and often they'll need to place stents to prevent this from happening again. So, percutaneous coronary intervention, commonly referred to as PCI, which we talked about on the last slide, is STEMI. This is the entrance through the femoral, radial, sometimes brachial arteries to reach the coronary arteries, in which a balloon is inflated and a stent is placed. You can see that in the image below, where the stent kind of wraps around the balloon's inflated to open it up, and the stent is left behind. I did want to talk about some specialty vascularization that is commonly used for the treatment of coronary heart disease, specifically in the case of very hard plaques that are difficult for the balloon to be able to reinflate and just more complicated revascularization. One of them is the rotational arthrectomy. That is when the surgeon uses a rapidly rotating burr coated with diamond chips, which I thought was kind of interesting because diamond is the hardest gemstone. So it's able to make contact with those plaques and grind away at the calcified atheroma within the artery. From that, those little particles are then able to leave into the bloodstream and be excreted. Similarly, there's also shockwave intravascular lithotripsy, which is where the catheter at the end of the catheter tip going up into the coronary arteries, it sends out pulse sonic waves that help to modify the intravascular calcium. It basically causes the plaque to fracture and those pieces fall off into the circulation. The last one is the excimer laser angioplasty. This one is still in clinical trials and isn't used as widely, but I still wanted to touch on it. It uses laser to produce monochromatic light energy to cause the ablation of plaque from the heat generation and shockwave. So similar to shockwave intravascular, but it also uses heat as well. So we'll see if in the next coming years that one becomes more mainstream. And that concludes our presentation on coronary heart disease. I hope that you enjoyed this presentation. If you have any questions, feel free to email me. I am always open to learning more about this topic, and I hope that you take away something that will help you in your practice one day.